So, hello, and I hope everybody's been getting a lot out of this evening. So I'll open the floor up to any questions that you have. Feel free to ask whatever you want. I'll run around with the microphone so that everybody can hear what you're saying. And when you do ask a question, if you can just say your first name first so that we can communicate back to you with using your name. So, any questions? Yes?
Hi, my name's Kathy. Tim, I'm interested to hear a little bit more about what's happening with Rose Bengal. I know that was a very good illustration of what it can do, but what are the percentages? How's it going?
So it's a good question. So it's not for everyone, I guess, is what the question is sort of alluding to. So it's a very early study. That was the whole sort of point of it. It's the patient that was up there was actually the first patient to have the treatment. He did very well. There are 8 patients on the study at the moment of 12, so there are 4 more patients to go. Probably about half have had a significant benefit to the treatment, not always long lasting, and so probably half have not really had the same sort of outcome. So it's not for everyone. So that's not dissimilar to immunotherapy in general. So I mean, immunotherapy is, as some may know, is now standard of care for melanoma, some lung cancers, a number of other cancers, in fact. And there will be a proportion of patients who respond very well. Switching the immune system back on is very important for their particular cancer, but there will be a proportion where it won't work.
Question. There was one that came through to us, and it was to do with using the CBD, the cannabis oil. We'll ask one of our clinicians, and Gabby's pointing to Tim. So views, thoughts, using any of the cannabis products with the cancer patients?
So I think the 2 points, I guess, that I would sort of comment on is there's no real evidence that it's an anti-cancer treatment, which I think is important. There's no real literature to support that. There is certainly some literature around it being a symptom based therapy, particularly appetite and well-being, nausea. And hence why the government were quite supportive, or are quite supportive, of being able to access medicinal cannabis. In fact, at COSA there were, I think, at least 2 booths, the cancer conference that was here just now, 2 booths on medicinal cannabis. But it is a bit more complex. You do have to have a licence to prescribe it, and even then the prescription, I think, is not quite straightforward. There appears to be a much easier way of getting cannabis products out and about, and personally I have no problem with patients exploring that. I mean, I'm not sure what the cost is. There was a comment again on COSA about people seeking out Olivia Newton-John's supplier. Apparently they're quite expensive, but so yeah, I mean, I think, look, there is some evidence around support. I mean, it's not that easy to get both on prescription or elsewhere, but I think it's certainly I'm certainly quite happy if patients want to explore it, and certainly I've had patients who feel better on it.
Yeah, I know Royal North Shore's been doing a study with a spray for pain control, and that's actually just closed to recruitment, so we're waiting to see what the results are. I did get a preliminary, some of the results where it was extremely variable with the amount that patients could actually have. Some patients had a lot and it had no effect, but and I did ask a question as to whether or not they had been a cannabis user before, but they hadn't been. So when they have used cannabis, they actually have to have a window where they're not using it at all, so that with this study that they can actually see that the effect is able to be monitored correctly, rather than having the results skewed. But I know one of the companies that was at the conference, they actually have a portal for specialists to go through to do the ordering. I think the price is around about sort of $200 or $300 for about a month's worth of the cannabis capsules. So yeah, and there's a lot of work being done into the nausea and vomiting in New South Wales as well. So
So just one quick comment about it, and that is that there has been, it's expensive to buy it medically, and so, naturally enough, the conversation sometimes does go to, well, shall I go somewhere very herbal and remote and perhaps buy my own or grow my own, and just some concerns from cancer pharmacists around the variability of the quality, especially if you're buying it from someone else, the variability in the quality and the dosage. So it's harder if you're getting it from somewhere else to really know how much you're actually taking. So we know that people are doing that, and it's understandable, but two things: make sure you talk to your doctor about it. We're not police, so but also just bear in mind that there can be that variability in quality and dosage.
Yeah. And plus, it depends what form it is, because there's two different types, and there's a very vast side effect differences. But with the CBD, you can actually drive. They found with some of the studies. So, but then some of the other products you can't drive. So it's sometimes a bit of a double whammy. So you've got something that's making you feel better, but then it's putting you sort of behind because you're not able to do your normal duties. Yes.
My name's Manuel, and question is for Simone. The Planet app that you were talking about, is that data that you put on there, is that available to all of the clinicians and physicians and the whole team that are looking after you, or is it just the hospital that data goes to?
So it's available to where that in that hospital. So any of the clinicians that are dealing with you within that hospital, for instance, Tim and Gabby would have access to all of it. I guess when we look further down, and obviously Jess as well, or whoever is actually in that area, obviously you have access to that as well. And if you wanted to, because it's on your phone, I guess this is a conversation, this has actually just come to me because I'm like, oh, you might want to share that potentially with your GP as well. But I guess because it's on your phone, you can go through it with them as well, especially if you're looking at around fatigue or anything with the quality of life, or the Bristol Stool Scale, you'd be able to share with the dietitian. That's up to you whether you'd want to do that. But in relation to the data, it would be fed straight into the registry, and it would be your treating doctors that have access to that.
You actually highlight a very interesting thing. I can't believe I've not thought of that before. So I look in this room and I identify a lot of you, but you've all come from a very broad range of referral doctors. So I sit here and go, okay, Tony, Michelle, Gunnison, Michelle G, North, South, Northern Territory. And so we might be, in the time that you're with us receiving your systemic therapy, you'll be with us for 6 to 8 months, and we've put a lot of work into helping you navigate support systems. But then when you leave us and those quality of life forms are with us, it's actually a very good point, and I'm not sure if that's something that
I guess we would be really, because this is in pilot stage, especially the app, we'd be really interested in feedback as to what you want with that, how you want it to work. Is it that you want to print up your reports or that sort of thing as well? So we'll be definitely asking those questions and reviewing those things as we go along. And as more people are using it, we'll be able to really gauge how people are using it and what they want out of it as well. Was that what you were thinking, of sharing it with, say, a GP or? Yeah.
People outside of the hospital.
Exactly. Yeah, definitely. And because it is your information, I mean, it was always that, we wanted it connected to the registry for that reason, so that it would minimise time and have better communication. But absolutely, I think that would make sense that you could then take that.
It's stored on.
It's stored on your phone,
Yeah,
so
so
you
it's
should
like
be able to.
Having a copy of your radiology or whatever. So you've actually got control of it. Yeah.
But I think then we'll look at different things like being able to print it up and all that sort of thing as well. Are there any questions? Because I have a bit of a question for the expert panel. Where I'm finding a lot of interest, or especially with AGITG this year, and I know you're probably going to know what I'm going to ask, is around the microbiome. When we look at our patients, with the debilitating symptoms such as IBS and you know, that's what our patients are legitimately being misdiagnosed with. You know, we're potentially looking at a research project or funding a research project where we start gathering the data. Again, we don't know what we don't know if we haven't been gathering the data, and looking at gathering the data on our grade 1, grade 2 and grade 3 patients. Then obviously we'd be investing in trying to see what does that data mean, but also associating it with environmental surveys as well, or, you know, geographic and demographic surveys, which I think that's how the whole microbiome testing is at the moment. So I just wanted to know, is there anything you know of that is happening in NETs, or is this something that you think is worthwhile as well?
Can I just ask before, or whilst you're answering it, does everybody know what a microbiome is? Yeah.
I was actually just going to make sure that everybody, it's everybody's unique. I'm glad there's some honest people here. So even though I thought I knew what it was all about, it took for me to be at AGI2G to understand that we all kind of start off with a small number of organisms in our gut when we're really, really little. And then we develop basically like a fingerprint of particular selective growth pattern of different organisms. And they're very important to us. And I don't think we've really appreciated the far-reaching effects for the whole body of the nature of our bowel, our poo. And I'll let Tim talk to you about the second part of the question, but I can tell you that there's been some incredible work done here in South Australia with a microbiome bank. And I know the concept is pretty crazy, but I listened to an incredible presentation by a young girl who had a renal transplant. Transplant was fine. She couldn't get away from going in and out of ICU because she had such severe diarrhoea. Her diarrhoea was caused from antibiotics, and we call that antibiotic colitis, antibiotic-associated inflammation, or Clostridium difficile. And her treatment came in the form of a poo transplant from her mother. And within 36 to 48 hours, she was cured. And so that's really very graphic, and that's one extreme. But the point is, we don't know what we don't know. And very much in this area, I'm actually really excited to think that there'd be the possibility of a trial, because as Jess and I will test you, we'll have patients sometimes and we're just sending you off. You've got to go have a faecal specimen. This doesn't seem right. I'm sure it's not just your net. And we don't necessarily find anything because we're very limited in what we can look for because we don't know what to look for yet. So that's the background of microbiome, and whether it's an eye condition, scleritis, autoimmune conditions, there's just all this expanding connection that we're not sure about. The next NET forum, give us a couple of years, I'm sure we'll have an update, but Tim might be able to speak to any known projects.
Oh, well, I mean, I think the crucial point is that, as you said, we don't really know, and I think that was the general theme of the talks. We know that it can change, particularly if you had chronic infections as a child. In particular, seems to be important. If you had lots of antibiotics, you have a very different microbiome to if you haven't. So there's that change over time from older people, no antibiotics, the antibiotic era. That's changed things. I think the crucial thing is that a lot of studies essentially are building in taking poo specimens. And obviously the best is via colonoscopic scrapings. So I think that's really the future, is to build that into studies so that then you can go back, look at the microbiome, look at what's happened with the study, which might be for another reason, but you can then correlate the outcome. So I think the other point to make is that the microbiome seems to then have an impact on immunotherapy. So there is some data around that for immunotherapy. So it does seem to be a very important part of the body, an organ of the body, so to speak. So I think the future studies will build that in, and then we'll get answers. So as you say, the next forum we might have more.
So you think collecting the data from our patients, though, as a start, like it would be like a microbiome bank for NET patients, that would be a good start?
Yeah, it's like a tissue bank. I mean, we've had tissue banks for ages,
Exactly.
collecting patients' specimens for future study, blood for circulating tumour cells, and I think building a poo bank is the next step.
Well, that's what I'm excited about. That's the next project I'm really keen to do.
Isn't it bizarre, the things that make us excited?
It is. Well, because I find that, you know, in any of the literature I've read, they're seeing a real correlation with the neuroendocrine system, especially around the anxiety and you know the different, and I just think there's got to be some sort of correlation between what our patients deal with. And I also thought, well, if there's very little molecular sort of markers in NETs, I think, you know, immunotherapy, particularly in PNETs, isn't very effective so far. We're looking at different studies to try and change the way the tumour is by potentially using different other elements like chemotherapy. But if it's like, well, if the tumour doesn't show something, could the microbiome bacteria and the genes in the microbiome be showing us something? So I'm very keen to get this poo bank up and running, so watch this space.
Your children aren't teenagers yet, just wait.
Can I ask a question? You mentioned about the exercise. I do have 2 patients who are runners and do get flushing that they feel limits their exercise. I mean, when you ask that question, is there any advice that you would give, or is there a change in exercise, or what do you compare?
I think given the lack of research, I can't say anything specifically, but what I would say is play around with what they're doing, get them to record what's happening when. So it may be something as simple as what's happening in the morning is different to what's happening at night, or weather, or something they've eaten. You know, what we typically say with a lot of our patients is just for the first sort of month, just record your life. It sounds really annoying. Record how hard things are, record how well you've slept, and then you start finding patterns, and it may be those patterns that then give some answers to whether or not that flushing is impacting their running or not, or when it's impacting and how they can train around it. Yeah.
Tim, is it considerable to, is it worth considering like an injection of short-acting octreotide pre-run or something like that, if that's seeming to be a trigger? Is that something that you would consider?
Well, you could, yeah. I mean, yeah, you could. I mean, I think their concern was that did it signal a problem and whether they should change their exercise. I mean, I'm not sure whether there's any way of being able to test for that. I mean, you could try to prevent it, I guess, with a preemptive dose of octreotide, but I guess their concern, which was the reason for the question, is, you know, should they then stop, or, you know, that...
Yeah. My suggestion was just on top of that would just be to monitor, say, heart rate, RPE, and if they're in a supervised facility, maybe look at blood pressure and oxygen and saturation. And just, if all those levels are fine, then I don't think that they would have an issue per se, unless they are experiencing side effects after running.
Holly, how often would you monitor patients that are on an exercise physiology program?
So typically if I have someone come in, I would monitor them for the first few sessions, seeing what's going on. If they have interesting symptoms, or if their blood pressure spikes or anything like that, we would typically keep monitoring them. We have some that will do blood pressures pre and post, or oxygen saturations pre and post, or during sessions. If they're not really showing any symptoms and their GPs aren't concerned and they've got no contraindications, we typically just try and let them enjoy their session. And then if they report any issues, then we go from there.
Yeah, possibly, yes.
So the question for the filming was, would it be worthwhile considering referring to Polly? And yeah.
Any more questions? Yep.
Sorry, my name's Debbie. I'm just wondering, you're on about the faecal. Why can't you connect it to the faecal occult blood tests they do over a certain age? So you're on about poo samples. So why can't you connect it to the faecal occult blood test that's done to people over a certain age?
So yeah, so the specimen has to be, I think, I'm pretty sure, stored in a particular way. So it's sort of to then, so there's a particular sort of, you know, tube it goes in, whereas the faecal occult blood test that you do from the government's invitation, which is to stress everyone that by the time it gets to the lab, it's in a different bottle and probably wouldn't give the same information. It was a great idea, but yeah.
And I guess the other thing with that is I feel like this is pretty non-invasive as well as a test. Biopsies, those sorts of things are really difficult. So I think I would hope that patient recruitment would be quite high on something like this because it's pretty simple. I've actually just done a little research on myself. I sent away for the kit to a Brisbane company, and although I did do it all very properly and then realised I came over to Adelaide and I'd left it on the kitchen table, so I duly called my mother and she's popped it in the post. So we'll watch this space again and I'll let you know how it goes. But it's really interesting just to go through the process and, fill out the survey. It had the Bristol stool scale, so I had to tell what it looked like and all that sort of thing. And again, we're talking amongst friends here because we all like to talk about our poo. I know, but this is what we talk about at length in our Facebook group as well. So I think that's what I'm also quite enthused about, is it's something that I think patients would really happily do because it is quite a very streamlined process now. It's becoming a bit of a big business.
Well, unfortunately, we've run out of time, so we thank the panel very much for all their input and the information, and I'll hand back over to Kate.
Thanks very much, Meredith.